I am mainly an endovascular guy at this stage of my career. I have younger partners who jumped on the structural heart bandwagon, so I don't do TAVR and things like that, but I was trained in the old days with that guy back there, where vascular was unique and cool. Now it's not, but that's what I got. So when I learned how to do radials, I started thinking, maybe this does work for some vascular things. So these are, when John sent me an email about 4 months ago asking me to do this, I started collecting some cases. So these are all in the last 4 months.
Great.
So go ahead. So this is just case-based.
Okay.
Can you go ahead? Oh, I got it. Never mind. My fault. I have no disclosures for this. All right, so in terms of experience, I would not consider myself a high volume radial operator. I've now done about 750 total cases since I got trained about 3 years ago. I am a high volume operator, vascular guy. I've done a lot of carotid stents, AAAs, and pretty much everything, and I do stroke intervention. This case is a patient who got a stent to the left common femoral artery from the left radial. Why would you do that? Well, he already has a fem-fem graft. The right iliac system is closed from top to the bottom. And you can't go in directly on the left side then and fix his left common femoral artery. He actually came in with rest pain in his left leg. CTA showed subtotal stenosis at the left common femoral anastomosis. So what are the technical issues? Well, the left radial, fortunately Jeff showed me once how to do that, is about 10 centimeters, maybe a little more, closer to the lower circulation than the right radial. Now, it doesn't sound like much, but I learned from sad experience that a multi-purpose 100 centimeter catheter doesn't get very close from the right radial. It gets a little closer from the left radial. And then as somebody said, you want to get some 125 centimeter multi-purpose diagnostic catheters if you're doing vascular, because it will help you. So in this case, we had a 125 centimeter catheter, and we can select iliacs, and even in women, shorter women, I've actually selected superficial femoral artery with that catheter. Most of the peripheral equipment, by the way, in the long versions, at least the Abbott equipment, is 135, much longer than coronary intervention equipment. So you can actually get down pretty low and do peripheral work. So this was the picture from the arm. You can see, for those of you who may not be used to this. So this was his fem-fem graft. This is the common femoral, and here is the lesion. Here's a balloon. This is really heavily calcified. You can see this ridge of calcium in the common femoral artery, and then this is stented. So all of this was done from the arm. Didn't take very long. I don't know that I could have done this any other way. This was a patient who had the aortic stents done from the left radial. This is a woman who, seriously, I measured this, from the table top to the top of her abdomen was 35 centimeters. I measured it. BMI is 48.
Is you a waist circumference?
That's the most I've ever done. Huh?
What was the waist circumference? Were you able to get a tape measure underneath there?
No.
Yeah.
It's amazing, and you're going to see the pictures are horrible.
Yeah.
So obviously, I didn't want to do a femoral artery approach. So we used the left radial. Pictures were really difficult to see. So end hole catheter actually was used to find the level of stenosis. And then we just put marks there to know where we had to go back, and then dilated. By the way, Trumo makes this destination sheath, really good sheath. It doesn't kink, can't kink. You use it to go contralateral all the time. But also, if you put it in from the wrist, you can use that to put that out into the thoracic descending aorta. Now you have a nice smooth 90 centimeter long pathway for anything you want to put in. It's a French sheath, not just a 6 French guide. So it makes doing peripheral work really nice. Okay, so this is a poor quality picture. I apologize, but it's patient size. This is the aorta, and this is a divot right out of the aorta. She could only walk about 50 feet. She claimed she was going to do a lot of exercise, because I actually asked, really, would it make a difference? She said, I want to get an exercise program, but I can't use my legs after 50 feet. So we did balloon angioplasty. The largest peripheral stents, unless you go to Palmaz shots, which are really big, you have to put them on about it depends, but 12 to 18 French sheath, which we weren't obviously going to use from a wrist. So these are the biggest ones you could use. This was post-dilating after a stent, but then we had to do another one below that. I just didn't bother to show it to you. So you can do a lot from the wrist. This one was a patient who you couldn't palpate anything in the iliacs. The patient had prior bypass surgery and also needed needed peripheral work done. So it had claudication of less than 100 feet and unstable angina. So I'd use the left radial. This was peripheral angiography. Right radial for this. Because they had their left radial used for bypass grafts.
Right.
Now, maybe in talking with you, I don't know, would either of you more expert people have used the ulnar on the left? Or you wouldn't?
With this being removed, people have done it.
Really?
Yeah, they've done it. It's.
And I'm not that expert.
Yeah, you can test it. I mean, you can take an quick angiogram with the angiocath, with a small angiocath. You can take if you have good intraocular circulation, I guess you can do it.
Yeah.
I had a case where I had a radial loop, and I was lazy to bail out to the other arm of the groin. I just bailed out to the same ipsilateral ulnar. And we had the pulse oximeter. It was 95%.
No, but I mean, if they had harvested the radial artery.
I understand, but that's a similar.
Yeah.
Similar scenario. If he had 2 sheaths, what he's saying is he put one in the radial and the ulnar, and then still was.
Yeah. Oh, I see what you're saying. You had
Yeah.
left the one in the
Right,
radial.
right,
Yeah. All right.
So
Next time.
it has been done. I mean, it's something bad happened again. You're sort of out there, but I mean, it's been done, and it's just amazing how though the hand tolerates. It doesn't need all that much blood flow. It's just sitting there doing.
You'll be my witness for the defense.
I'll sign up.
All right. So these are the peripheral stuff. This was interesting because I wasn't sure how I was going to get there, and now I do this. I've done this on several other cases. I use an S1 catheter, Simmons 1, a lot for my right radial work to get into carotids and subclavian. But once I had this here, then I just put a glide wire out, soft glide wire down into the axillary, and then switch to a Lima, standard Lima, and torqued it. And you can see that's pretty good quality IMA angiogram, all done from the right arm.
Yep. And
I've done that, I don't know, 2 or 3 times, not frequently, but keep that in your bag of tricks. Okay, carotids, diagnostic angiograms, and left subclavian from the right radial. This case, the entire case was done in 14 minutes, and you just use a Simmons 1. Great catheter, that's 4 French, it's glide. So, I mean, it's almost as atraumatic as you could possibly get. So there's a subclavian like we did before. You just torque it a tiny bit. You push down towards the aortic valve and then bring it up and torque it slightly, and you'll get into what's obviously catheters down here, pretty nasty carotid system. And then if you torque it, you'll close the loop of the bottom part here and then pull it back into the innominate. If you go to RAO, you'll spread out the common carotid from the subclavian and then just pull back gently and it'll subselect into the right common carotid origin. Great pictures. Okay. This was an interesting case. So I had done a AAA stent graft, and we do a follow-up CT. at 1 month approximately, and it said the patient had a tight left renal. Of course, with stent grafts, you try to put the EVAR as close as you can to the renal artery. That's just standard procedure. I've only ever actually stented one renal after a EVAR, and it was not a fun case. So this patient had terrible tortuosity. It was a difficult case to begin with. And I tried to do this from the leg, which was pretty standard, and you'll see it didn't work too well. So this is this guy's calcified iliac system. Needless to say, torquing of a catheter in that is not very friendly. I did try. So this is the destination sheath, which if you can get it up there, again, gives you pretty good push through the sheath. But then you're trying to get in this case, a Lima, and I tried a Simmons both, and I never really could get it to come back down. And you can see it looks like there's a tight stenosis. I just didn't believe it. You just haven't had that problem. So I switched and said, okay, I'm going to try from the radial. So this is the 125 centimeter multi. Now you can get, there's a little bit of a aneurysm right here in the aorta, but you can see now there is no stenosis, so it completely changed the outcome of this case. It made me a lot happier. But then my nurse said, you have to shoot his mesenteric vessels because he's lost 15 pounds and he won't eat. Okay, Julie. So I was already there.
Did you ask her why that was a bad thing?
Huh?
Why is that a bad thing? You know,
well, it's just, it was hard enough to get that done. It's not that it was bad. So this is the superior mesenteric artery, and the guy has an 80% stenosis. This is his celiac artery. He has a 70% stenosis. So she was right. Yeah. And I did come back, and from the arm, fixed, I believe it was the superior mesenteric, left the other one alone, and he's gained back about 7 pounds so far in about a month. So he's happy. And then I think this is the last one. This is a right carotid stent from the right radial. Carotid stent patients have a huge amount of comorbidities, almost by definition. I've done about 15 to 20 of these now from the right radial. I will say it only works in about 2/3 of patients, depending on the tightness of the angle between the common femoral and the right subclavian. So if it's too tight, you're not going to get the sheath to go around. We use the destination sheath, like I said. If you want to try this, use a woolly wire. We typically use a supercore or an Amplatz from the groin, but they're too stiff and they just prolapse right down into the aorta if you try it from the wrist. So this is an example here of, we have a wire and the Simmons 1 now in the carotid system. We use a quarter, that's actually a quarter, so we know it's 24.1 millimeters. That's how we do our vessel sizing. This is the lesion, so just so you don't think we're doing this on 50% disease. This is the destination sheath, and it goes nicely. And once it's in there, you now have a rail. I mean, it's amazing what the quality of the pushability is. And then this is the tip of the sheath and the lesion, and that's after the stent.